rhinology, you have a whole mix of patients. You have patients with chronic rhinosinusitis, you have patients who have trouble breathing through their nose, and then you have the cancer side of it. And they all kind of present the same up front for a lot of people. And so all of my patients, cancer or otherwise, we have to start out by just trying to figure out what's going on with them and having a lot of empathy for what they're going through. And then once you get to that terrible diagnosis of cancer, you want your patients to know that they're not alone, right? And so I personally think it's worthwhile to take the time not to make people feel rushed, give them the time to process their information, be available for questions afterwards, because you hear that C word, right? And then everything just stops. No matter how much information I give you at the time of your diagnosis, you're going to process probably 15% of that. And then you leave and you have a million questions, and maybe we need to do another telehealth appointment so that we can have some time to go through everything we talked about again, or you have a question here or there. So part of our cancer care is that we do have a patient advocate and patient coordinator that works with the skull-based program. And so I think that is a key component of our skull-based program, is that we have this extra person to help patients as they're navigating through the process of not just getting the cancer diagnosis, but starting thinking about what's the treatment going to be. Is that surgery? Is that radiation? Is that chemotherapy? Or some combination in between? I'm a big believer that you make your own decision. My job as a physician is to give you the information to the best of my ability. My job is to tell you the various options and what the pros and cons are of each. We may have a standard treatment in that we know that this has the best outcome. That standard treatment may still not be the best treatment for you given the issues in your own life, your family situation, your work situation, your goals, right? And so I think part of any cancer treatment is not only knowing what the medicine literature is, but also knowing what your patient goals are. And you have to have a conversation and be open to hearing their opinions so you can work as a team to come to the best solution. Having a brain tumor center is so important for patient care. Brain tumors that involve the skull base are not incredibly common, but there's not a lot of centers across the country that take care of these types of patients. And so having this central place where you can come, where you have experts who do take care of these people, is so important. As a rhinologist, we do have occasional sinonasal malignancies that go up and involve the skull base, but most of the skull-based tumors start on the brain side and so are primarily managed by the neurosurgeons, with the thought being that as a rhinologist, it's our job to help get them there. We're able to go through the nose, no cuts on the outside, using cameras inside the nose and instruments inside the nose, so that we create a pathway for the neurosurgeons to reach those tumors without having to do a big incision across the top of the head. And then after they take out the tumor, it's also our job to make sure that the brain is closed from the outside world. Obviously, you don't want to leave your brain open to the outside world because that would predispose you to infections. And so as a rhinologist, our job is to use tissues either inside the nose or from other parts of the body to seal off the brain from the outside world once you've removed the tumor. When I was thinking about my future in academic medicine, I had always planned for my research to be focused on quality of life outcomes for both chronic rhinosinusitis and sinonasal tumors. And then COVID happened. And so COVID kind of changed everything for my research. And I realized how many patients were losing their smell and having changes of their smell, even if it was an actual loss. And the fact that there was very little treatment for those people. So my research now is focused primarily on treatment for COVID-mediated smell loss and smell change. What's great about that is it doesn't just apply to people with COVID. While that's the focus right now, in the long term, it's very applicable for anybody, right? People with chronic rhinosinusitis often lose their sense of smell. In addition, people who have sinonasal tumors often lose their sense of smell. Some, like esthesioneuroblastomas, actually come from the smell nerve itself. So part of removing that tumor is taking out the smell nerve. So smell loss transcends COVID, and it applies to all of the patients that I see. So as we continue to work to find new treatments for COVID, the hope is that we can continue to expand that and treat all of our patients, including those with sinonasal malignancies and skull-based malignancies. When I think about kind of the path that got me here, so I didn't have your standard path. My parents are both researchers. I grew up in a very analytical household that was always thinking about how to improve medicine. They were medical researchers. And then when I went to college, I was an engineering major. So I was not a biology major, and I was an engineering major because I have the kind of mind of, I really like to solve problems, right? I see a problem and I want to create a solution. It was kind of the perfect major for me and a really good segue for me into medicine, because I didn't go into medicine just to stand by the standard treatment. I wanted to progress the field, and I wanted new innovation, both in technology and in medical therapies. My path was maybe not the standard path in that I came from the engineering side. In a lot of ways, it's been a perfect merger of innovation and medicine.